I'm going to fly through this. I do apologise. We'll put this together at lunchtime today. What I'm going to try and go through is what the official DSM-4 and 5 diagnoses of drug use and addiction and alcoholism. That's the kind of thing that Catherine was talking about, what the skills we need, the skills that we use with those kind of issues, motivational interviewing. I'm going to touch on just these subjects. I don't think it's going to go into any detail because it's not. Prescribing, lived experience, a little bit about how registrants might present and that stigma and the NMC. I'm going to talk a little bit about drug testing, hair testing, oral fluid testing, and urine testing. And the external view of NMCWatch, how much do we help? Meaning, I suppose, when do we draw the line at where we help? Because obviously if someone's got a big drug problem, we don't want to be seen as an organisation for getting people back on the register who don't actually deserve, or it isn't appropriate at this time for them to be back on the register. So we need to be quite careful in that regard. And what does the DSM-4 and 5 say? With DSM, Diagnostic and Statistical Manual number 4, said that it was 2 disorders: substance abuse and substance dependence, alcohol abuse and alcohol dependence. But in the DSM-5, that was all put together as substance misuse disorder or alcohol misuse disorder. Does that actually help any of us? I don't think it does, because addiction and alcoholism is really ingrained in personality, your choices and your experience. If you imagine there's a part of your brain that says where you decide that you will do something and another part that you won't, and all that decision making is based in your experience, your trauma, your personality, your memories, it's very difficult to pin someone down as to why someone uses drugs over why someone else would. There are people with very low self-esteem who use drugs, and there are people with very, very good backgrounds and very high self-esteem who use drugs and get addicted. So it's pretty indiscriminate, really. I'm going to talk a little bit about stages of the addiction cycle. I'm talking here about, as a drugs worker, what do I see? What do drugs workers see when they work with clients? This isn't necessarily our registrants that we've got an NMCWatch, but the average use, the average cycle or career, if you like, of a drug user who's lost an addiction or alcoholism is about 12 to 15 years. It starts off with no initial pressure to address it. They use up all their immediate resources. At the beginning stage, we do not rescue them from their consequences. We call the first stage of drug treatment coercive treatment. We let prison, drug treatment and testing orders. We minimise harm to the family, to the public. We look after their health. But we don't necessarily rescue them from the consequences of their drug use, because we want it to get sufficiently bad for them to make a decision to do something about it, okay? So I just want to touch on what harm minimisation is. Harm minimisation, the best model I can think of, come from New York in the 70s. They were trying to get girls who were on the street, not, cool girls, basically, in very dire straits, and none of them wanted to do anything about their drug addiction. So they asked these girls what they wanted to do, and they said they wanted somewhere to get their makeup done and have foot rubs and all sorts of other things to help them doing what they do with their day. So they did that, and they saw a 45% increase in those girls getting clean. So addressing one harm doesn't necessarily mean you don't impact others. So that's kind of the crux of harm minimisation. You work with clients at the beginning on what they do want to do, and then you'll find that they're with you then. I want to talk a little bit about motivational interviewing, because that's the main technique that I always use with registrants. I always use with clients, and I'm going to go, and some of you may have heard about it. It's where you begin to use motivational interviewing techniques once the client is beginning to make a decision. Motivational interviewing techniques kind of roll with any resistance. It works primarily with a client's ambivalence. We'll go into ambivalence a little bit later. And it fans the embers under a person's already present dissatisfaction. So it ignores the negative and encourages talk about the positive that they want to do. I'll say a bit more about that in a little bit. That's the cycle of change there. It's the main crux of drug and alcohol work. People enter at pre-contemplation before they've even decided they want to do anything about a problem. The problem gets difficult, and then they begin to contemplate doing something about it. Then they become determined. Then they take the action, and then they may exit or re-exit at any stage there because they can relapse. Eventually, the change is maintained, or they go around the cycle again. Now, the main crux of what I want to say about working with registrants and working with, as we get better at what we do at NMCWatch, the main crux of motivational interviewing is working with someone's ambivalence. So what does it mean? If any one of you have ever seen the film Girl Interrupted, you'll know this. Ambi means both ways, and valence means vigorously. So ambivalence actually means torn between two difficult decisions. And the presentation of that is, oh, I don't care, can't be bothered, things are okay as they are, because either way is difficult. So they just accept the status quo. Cycle of Change was written around helping people stop smoking. And it's a really good example of where people want to smoke and they know they shouldn't smoke. So they just block it out of their mind and remain ambivalent. And that's where we work in motivational interviewing. The most likely thing you're going to see at NMCWatch, which I've seen, is codeine use, because of our access to prescription drugs as opposed to illicit street drugs. Alcohol issues, I've seen cocaine use. Those are the three I've seen at NMCWatch with clients, and maybe some of you. We've got a cocaine support group in NMCWatch at the moment. I often talk to people about the fact that I might talk in an AA meeting. I've not drunk for many, many years, and I'm very, very open about my recovery. I think I'm of the opinion that it's very, very important that people in positions of authority, solicitors, doctors, policemen, whoever, should be very, very open about recovery. There's nothing to be ashamed of anymore. So that's kind of ambivalence. And where can we refer to? Can we actually send anyone at NMCWatch to anywhere? Because what they're going to do is they're going to come, they're going to say, everyone wants to get back on the register. Everyone wants to succeed at their fitness to practice. Is it appropriate that someone succeeds without addressing their drug problem? I'm not sure. Everybody or every person would need to make that. I would suggest that if we want to be taken seriously going forward, we need to begin to consider the code of conduct and whether someone's suitable for the register too. But I've got an idea at the end of where people can go. It's just an idea from what I do with people. So I can say honestly that they've done this and I can see it, and I'll come up to that at the end. Nurse involvement in someone's drug treatment, not for us necessarily, but certainly if someone's got a drug problem and they went somewhere, at what point would they see a nurse? They'd see a nurse at the beginning. They'd see a nurse when they need prescribing. In Scotland, we have these medication-assisted therapy standards where people turn up and have to be prescribed within a day. And that's very, very difficult to do because you have to evidence that they are taking the drug they want replaced, which is difficult. They're normally given methadone, which is liquid, or physetone, which is the tablet of the same drug, or buprenorphine, which is a different drug entirely. The aim is to stabilize them. Sometime later, whenever they're ready, using motivational interviewing to encourage them to reduce. You can tell I've written this recently because I've encouraged twice. The methadone, when it's given initially, can be given up to 140 plus mils per day. You transition to buprenorphine when you get that down to around 30 mils a day. It's a very, very different drug. And buprenorphine promotes a societal and values change. I'm just going to say a little bit about it because I think it's quite important if we have a client on either. This is opiate treatment, by the way, codeine being an opiate. Buprenorphine is a dual-acting drug. It's an agonist and an antagonist. It stimulates the pathway to make you feel like you've taken heroin, but it blocks, or opiates, but it also blocks, so it stops all other opiates working. So it's kind of like giving someone an opiate and naloxone to block opiate pathways at the same time. It's a very complicated drug. So if you give it when someone's on above 30 mil, it might send them into withdrawals. But the reason it changes people's societal, social connections and values is they begin to stop using opiates on top. So someone with a codeine problem or a heroin problem, after a few weeks on buprenorphine, realizes that using everything else on top, no point. And then they move out of the circles where they might meet their dealer or might have to take off the trolley or whatever they're doing negatively. It makes no point to do that. So you'll find people on buprenorphine doing voluntary work, going back to college, getting a job a year after moving from methadone. Whereas methadone, you can use anything you want on top, it will still work. The next bit is then the next stage is to encourage a detox, whether that community residential day program. The next step is to maintain recovery. And then at the end, maybe when people leave services 6 months or a year later, they're asked to come back and do voluntary work. They're maintaining their sobriety by using their lived experience as volunteering, that kind of thing. Talking more about NMCWatch. Some of these are up for discussion. They're just things that come out of my brain. Nurse disclosure and the truth. Are people honest when they go to? When I was at the NMC and I heard a couple of people, I spoke to 2 or 3 people where alcohol was clearly involved in their case, but their denial was very strong. It was someone's fight. It was an issue at work. They didn't seem to correlate the fact that they were at a drink problem and they were quite anxious in the morning as a result of detoxing. It's it's the last place to go looking for the issue. Are they actually ready to return? It's another thing that we need to consider. Is NMCWatch's reputation? How do we want to be viewed in the future? Now, I'll put this in there just so people know. Myself and Catherine have been talking about a Wounded Healer conference next year. I've submitted an abstract for us to do something up there on addiction. And the Wounded Healer conference is from NHS Practitioner Health. It's where doctors and nurses and anyone medical is referred to get help for addiction, mental illness, bipolar, schizophrenia, any serious issues. So you don't have to go to your local service. It's a central NHS service where you can self-refer as a nurse, doctor, medic, paramedic, whatever. Well, if we go up there and we do that presentation, I personally, myself and Catherine have discussed this, I hope she doesn't mind me saying, it's going to increase our credibility among statutory services without a shadow of a doubt, because we're going to go up there and talk about how we help nurses and how they're missing a trick by getting involved with fitness to practice. So I say that because how do you want to be viewed? I think addressing someone's drug or drink problem is important prior to going back on the register myself. I certainly wouldn't have been able to get back on without addressing it, that's for sure. And how do we evidence recovery? I'll say a little bit something about that at the very end. I just want to quickly talk about my role in my job at the minute. My role is in drug testing and monitoring at the moment. It's toxicology. I deal with hair strand testing around the country, which is a very chronological test for sustained use. It's very inexact. It won't tell you whether they've used just at the weekend or just on a Wednesday. It will just give you a high amount over the last 6 months. 1 centimetre of hair gives you a month's worth of drug taking or alcohol consumption. So if you take 6 centimetres of hair, that will give you how much I've drunk in the last 6 months. But it won't tell you if I'm getting really, really drunk at the weekend or whether I'm drinking every day. So it's very inexact. Oral fluids, saliva testing, very accurate over 2 to 3 days with no adulteration attempts, because you take the test face to face. And then there's urine testing, which is also accurate, but it's got a 6% attempt at adulteration because you need to give the pot to someone. They go off to the loo and people with addiction troubles, unfortunately, can be quite tricky, let's say. And so 1 out of 20 tests, someone's tried to fool you. Generally speaking, lab testing for those three is legally defensible. Point of care testing, where you get the result there and then off the device, is not legally defensible. So I don't think the NMC will put someone back on the register on the basis of a point of care test, because they could put someone on who's given you a negative test, but in actual fact has, because lab testing is far more accurate. I'm happy to be contacted on these matters if anyone wants to. My email address is there. So summary is, for us, the DSM-5 is very clear. Addiction is an official diagnosis. Alcoholism is an official diagnosis. It might be behavioural, it might involve crime, but it's also a health issue. It's a personality disorder or form of mild personality disorder. It's indiscriminate. There is no way of testing for it. When I went to NMC, the first question they asked me was, can you evidence you've recovered from alcoholism? And my answer was, I can't even evidence I've got it. How can I evidence I haven't got it? And the next question was, can you guarantee you won't drink again? And I had to say no. I can guarantee if I don't keep doing what I'm doing, there's a chance of it. So I need to stay vigilant. Motivational interview and skills, please remember those. I'm happy to be contacted. And the last bit, ambivalence. It's the most helpful comment. If, for example, someone says to me, I went out last night, I took cocaine and it was fantastic, I say nothing in return. And then when they say, but I spent 200 quid, I might say, so what do you have to go without now as a result of that? I enhance the negative parts of it for them and I completely ignore the rest. So you're trying to make them more dissatisfied than they would normally be. That's it. That's my email address. Sorry, it flew through. You can ask some questions. And just at the end, this is what I do with people when I've got 2 members of NMCWatch coming to a meeting that I'm doing in half an hour. This is something that happens very often. I'm speaking tonight. It's a 12-step meeting. It's not the only way to do your recovery, but it is something that we can ask people. I can post this. It just happens to be that I'm talking tonight at 7:30. I can post this, say, once a month on NMCWatch, and anyone can say on there, if you've got a problem with drink or drugs, go along. Now, and other people will know they're there. I mean, we won't be able to say it necessarily, but it is a free resource for us to send someone into. It's just a Zoom meeting. 2 people, possibly 3, are coming from the coding group tonight to listen to me share, which is helpful because I always say I'm a nurse. But that's one thing. If there's anything else, I will also post it. This is just a regular Brighton one. It happens at 7 o'clock every evening, 7 days a week. And there's always at least 20 people in there. Hopefully there might be a bit more tonight. Yeah, so that's the end of it, really. I'm sorry if it was very, very quick. I just wanted to make sure.
Okay, right. Thanks very much, Kenny. I mean, as chairman, of course, I'm never unhappy when things are quick, particularly if they stick to time. So that's great. Have you got any question? I mean, actually, I was thinking one because I know we haven't done, or we wouldn't do, and it'd be tricky to do a sort of a census or things like that. But have you any idea what proportion of people who get involved with NMCW, for example, might be affected by the issues that you're talking about there? You know, is it 1 in 1,000 or is it 50%? You know, it's about that sort of range.
We'd have to do some kind of research and have a look at that across our members. But I'll give you an example. When I was up at my second visit to the NMC, I met 5 people in the waiting room. 4 out of 5 had alcohol involved in their case. They weren't there for having a drink problem. Mm-hmm. They were there for other issues. One was there because she had an argument, because she was drunk. One was there because she took her eye off the bought work, because she was more concerned about drinking. And one was there for the second time because she got pulled for shouting outside work or something. So it's really strange. It's like we'll have someone come in and get in trouble, but when you dig down, they've got some kind of coding issue, or then they say, well, I'm using cocaine at the weekends and I wasn't concentrating. Unfortunately, recreational drug use is so much higher than when we first went on the register. It's now not accepted, but it's far more acceptable. So I would say we can have a look at how many people are in the codeine support group. It's quite a few, and they're not referred because of codeine; they're referred for something else.
Okay,
yeah.
so we don't know exact numbers, but
No.
the impression I'm getting is it's not insubstantial. It's not a sort of a marginal issue. It's something which in terms of referrals is something which is not something.
No, well, as an example, I've sent that flyer for me sharing tonight to 7 members of NMCWatch just today. So there's a number that I don't talk about them directly, but there's quite a few. Drinking drug, so it is quite prevalent, unfortunately.
Anybody else got any questions for Kenny on his presentation before he?
I apologise for the speed of it.
Before he doesn't actually dash off to another meeting, he just switches cameras for another meeting. But,
yeah, I'm not dashing off straight away. I've still got some time.
Well, my question is, Kenny, how can you, as your colleagues go, how can you identify if they've got a problem? Because some people are very good at hiding it. Because I used to work in London, I used to commute every day, and one of the colleagues I worked with, well, at the time, was a judge, and he would always start his morning at 7:30 with a whiskey.
Yeah.
But he said he wasn't an alcoholic.
Yeah.
You said. So, but if their behavior is normal, or in the sense of normal, how would you, if I hadn't seen him drinking, I wouldn't have known that he drank. But how would you be able to identify someone and help them?
Well, that's a really good question. One of the things I would surmise, and this is the kind of thing that where I think we need to be careful. There's a real tendency to want to really help people, but we don't want to be so helpful that we're putting people back on the register who aren't ready to go back on the register. Right? I personally think that I was ready to go back on the register. I think I've panned that out over the last 8 years, but I don't know that everyone is. I think we have to rely on their honesty and their insight. I think it's perfectly reasonable to say to someone, was drug use or alcoholism or alcohol play any part in the reason that you... I used to work in a police station, and we used to go and see people who got arrested, and I used to say to them, I'm not here to look at why you're arrested, the offence you've committed. I'm here to look at why you committed that offence. Do you have a drink or drug problem that helped you? And that's kind of what we've got to say with clients, nurses. Has drugs or alcohol played any part in your referral or the reason that you did what you did to make yourself get referred? Is that why you took your eye off the ball? Is that why your skin and nicked something? Is that why you got in a fight? Is that why you didn't have the clarity to post that stupid thing on Facebook? And those kind of questions we have to kind of be. The tendency is, it's a bit like suicide. One tendency is when we're worried about someone hurting themselves, we're really reluctant to say, are you thinking about committing suicide? But actually, the research shows that the most important thing to say to someone who's thinking of hurting themselves is, are you thinking of committing suicide? You've got to say it. You've got to verbalize it. So don't be afraid. The worst thing that's happened is you're going to offend someone. They're already offended by the NMC anyway. I'll just get on with it,
Yeah. Okay.
Hi, Catherine.
Okay,
thank you.
Any other questions? Catherine? Catherine's got her hand up there.
Yeah, hi. Thanks, Kenny. That was really, really useful. So how can we, well, 2 questions really. How can we get those honest conversations with people on our group? Because that's something which I think I'm getting better at. I think I'm getting better at challenging people a little bit more to sort of be a bit more honest with us. And definitely what we always say is we're not here to judge you. We're here to, help you get through it. And how well equipped are the NMC to deal with this issue? Because we hear quite often about people being sent for or being made to have drug and alcohol testing, and it being extremely traumatic for them.
I think this, if you're being sent for drug and alcohol testing, you're kind of not as, I wasn't sent for drug and alcohol testing because I went there and said, obviously I had this major problem with alcohol and now I don't drink, and I was able to evidence that with people. So if you're being sent for drug testing, the NMC aren't sure whether you're using or drinking or not, which isn't a very good sign, is it? I personally don't know if we should be offering the support earlier than that, so that while they're with NMCWatch, they can begin to address it. And it's a bit like what I said, being really explicit about saying, we'll help you deal with drug problems and alcohol problems. These are the things we can refer and signpost to. Every now and then I post a philosophy, and I have considered posting something every month or two saying, there's this support group, there's here where I'm speaking, there's this, and actually making not a campaign, but a small campaign out of it to make sure that everyone on NMCWatch is always reminded that we can't address these issues, but we can send you somewhere that does. It's free, get on with it, and then come back with that evidence. You know, someone said the other day that they did a drug awareness course. I don't know how far that will go at the NMC, a one-day course about drug awareness. But, you know, I've got two guys who come to meetings with me. Now, I'm happy if they go in front of the NMC and they have their hearings and they say to me, can you, am I able to break your anonymity and say you were there? And they say, yes, I'm happy to say they were there. I can't say how solid their recovery is, but I can say they're there because I've been there with them. And that's the kind of thing, really, another nurse. And there are other people who would be in the meeting. I don't really rate their recovery. I'm a bit reluctant, and I can make a decision. I'm not quite ready to give you so, you know, you have to be quite.
Catherine, you had a second question, Catherine. Yeah.
We have to be careful. We're back. You know as well as I do, Catherine. You know as well as I do that we have to be quite careful with NMCWatch's reputation. I don't have to tell you that.
Yes.
Can't go singing the praises of people who are still misbehaving or doing what it was they did when they got referred. You know,
absolutely.
It needs to have some.
And I think we need to get braver at those conversations with people and actually ask them more specific questions, like you're saying. You know, even perhaps when we first have that contact with them. You know,
I mean, I'm more than happy for you to say that the safeguarding lead is someone who's in recovery himself. You're not going to get judged, and you know, make sure that they know there are people on NMCWatch who are very open about the fact that they take codeine or they've got a problem or drug problem. There's lots. There's people who've contacted me. It's not a hidden issue. You know, it doesn't need to be behind the scenes at all.
Yeah. Well, that's something certainly carry on thinking about, can't we, and try and bring in more with the admin and buddy roles as well. Brilliant, thank you.
Anybody else any questions for Kenny? No, I can't see anybody waving a hand. Well, thanks very much, Kenny.
Can I just say, one of the biggest questions I get from people as well is they ask me about drug testing. They ask about what? They ask me about drug testing. They ask me about I have to give hair.
Yeah.
Is there a way? How long will it be able to go back? And they ask me these toxicology questions. I've had to give saliva. How long will it stay in my system? I'm very wary around those questions, because if someone says, how long will codeine stay in my system? What they're asking me is, when can I use it and not get caught? Because you have to be quite careful. But anything like that, and then I have had quite a few of those questions, just come at my email address. I'll put it in the chat. Feel free to contact me.